Welcome to another edition of Back Talk, brought to you from the Southeastern Studios in Mount Pleasant, South Carolina. Each episode, you'll hear from board-certified physicians as they explore the latest in medical procedures that are now helping get more and more people out of pain and back to their active lives.
The purpose of us doing this podcast, we're talking about the latest and greatest, the latest medical advances. What do you think is the biggest medical advance you've seen in spinal medicine, or even, I guess I'm saying this to a neurosurgeon or orthopedic medicine that you know?
Well, I mean, in my practice, I think probably the biggest impact of anything I've seen in spine surgery has been, minimally invasive surgery, and not necessarily for the reasons that you might think or that people might think is, we always were taught, or when we were learning how to do minimally invasive surgery, it's a small, tiny incision, and, less tissue damage during the surgery. And I think that's all true to a certain extent, but I think the really revolutionary thing that I don't know that people anticipated is the reduction in infection with minimally invasive surgery. And, just in training, we were doing cases through big open incisions, and I think we had a low infection rate where I trained at the University of Kentucky, but, I think it would be on the order of 3 to 5%. Do you think that's a fair number years ago, or maybe 3%, something like that? And now I think it's way less than 1%.
Right. The minimally invasive surgery is exactly how it sounds. It's done through a smaller incision, and there are special retractors that you can use that allow you to split the muscle rather than cut the muscle.
Right.
And so as graphic as it might seem, it's almost like the difference between cutting into a steak to see if it's done and putting a thermometer into it to see if it's done, right? You're not disrupting muscle fibers when you split.
I like that.
Right.
Can I use that?
Sure. You're splitting the muscle rather than cutting the muscle, and I've got to believe that that's a huge part of the decreased morbidity, the reason that people are now in the hospital for a day after a big minimally invasive spine surgery, if there's such a thing as a big minimally invasive surgery. It's
right.
Kind of an oxymoron.
Yeah, and I think another way to think about it is, which is maybe a little bit more technical than how you described it, is, with traditional surgery and traditional incisions, you're cutting the muscle, and you're using a retractor to pull open the incision, and then when you close it, there's a space, and in the textbooks it's potential space, meaning that there's now an open cavity underneath the skin where you pull the muscle away from the bone, and that cavity generally fills with fluid, and it doesn't have a good blood supply, and it just doesn't heal as well, and it's a higher risk for infection. And then when you do minimally invasive surgery, that potential space, that cavity underneath the skin doesn't exist, because like what you're saying, you split through the muscle to do the surgery, and when you take the retractor out, the tissue just comes back together, and there's no place for an infection to take hold.
Right. That potential space is also referred to as dead space by some people, which is a little graphic, but you're right. It's just a potential problem.
Yeah.
Right.
Yeah.
For me, when we talk about what the biggest advance, at least in orthopedics, I think that most orthopedic doctors would agree that the biggest advance by far in orthopedics in our lifetime has been joint replacement.
Right. Yeah. I know very little about joint replacement, with my background, but
right. Well, I mean, I think that you don't have to be an orthopedic doctor to understand what a knee replacement is and what a hip replacement is, right? And hip replacements have not been around for as long as you might think, right? They were first approved, I want to say, in 1969 by the FDA. And the spine has had a hard time catching up, right? Artificial hips were placed in 69, artificial knees, I think a year later. There have been artificial shoulders, artificial knuckles, but artificial discs in the spine really haven't come into the limelight until the last maybe 10 to 20 years.
Well, I mean, before I got here, you guys, were involved in the disc replacement trials. And obviously, you know a lot more about it than I do, but that was back in 2002, 2003, something like that, where you started doing lumbar disc replacements.
Right. As part of the first FDA trials, we put in the first artificial disc replacements in the low back and the neck, cervical and lumbar artificial disc replacements. And it's interesting in that the first disc replacements that we thought were going to really change the narrative were low back or lumbar artificial disc replacements. But as it turned out, to do a low back or a lumbar artificial disc replacement requires a pretty extensive approach through the abdomen, right? And going back in to do a second operation through the abdomen is very difficult when you have that first operation. And so as a consequence, a lot of the artificial lumbar discs developed problems that couldn't be fixed easily. And oddly, in the neck or the cervical spine, the artificial discs have been a tremendous benefit. That doing one or more artificial discs in the neck is easily doable. It allows you to have continued motion in your neck, and has been something that has really taken off, whereas artificial disc replacement in the lumbar spine is still lagging behind.
Right. I agree with that. And I did a few artificial lumbar discs, and I think the patients did okay, but, for reasons maybe that I don't fully understand, insurance companies have basically stopped paying for them. I think that's mainly because the outcomes weren't as good as what people were hoping. But that's certainly not the case with the cervical discs. And, you were asking about, innovation. I think the cervical disc devices have come a long way over the last 15 years, to the point at which now there are devices that are basically completely radiolucent, which obviously you know what that means, but to anybody that's listening, radiolucence means that you can't see it on X-ray. You can just see a little bit of on X-ray and on MRI. And so if you have problems down the road, taking another X-ray or MRI scan, you can see the other levels really well. And whereas in some of the older artificial discs, they have some titanium and metal in them, and sometimes other metals. And MRI doesn't like metal very much. A lot of people know that because MRI is a big magnet, and so when you get the X-ray or the MRI specifically, a lot of times it obscures problems. You can't see as well as you need to see. So that's been a really welcome change in the last really year and a half, where some of the latest devices, you can get an MRI scan and have a great look at the other levels, because, unfortunately, patients that have disc problems tend to have more than one disc problem over their lifetime. So,
right. I think that when it comes to microsurgery or minimally invasive surgery and disc replacement, especially in the cervical spine, I don't think that most people understand that. And you, I'll give you a little credit. You are the premier disc replacement surgeon that I know in the cervical spine. That it's an operation that goes through the front of your neck. It's about a 1-inch incision, 1.5-inch incision that doesn't cut
smaller
muscle.
than that.
It's
I mean, when you do it, it's
right.
A couple of inches.
Right.
Yeah.
No, but a 1-inch incision, then a 1-inch incision through one of the natural creases in your neck, so that you really can't see the scar. And with the surgery, you can do it in such a way that you don't cut muscle, you don't cut bone, you don't lose blood, and the operation to remove the disc under a microscope and replace it takes roughly an hour.
Yeah, I think that's fair. I think, I tell patients it's, typically 20 to 30 minutes per level
Right.
to do that surgery, plus a little time to get down to the front of the spine, and then to close the incision. So, about 20 minutes per level, and maybe 10 minutes on either side to do the exposure and close the incision. So,
Right. And artificial disc replacements are evolving. Like you said, the ones that we're putting in today are marked improvement from the ones that we put in even 5 years ago.
right.
I think in 20 years, we're going to say, why did we ever do fusions?
Yeah, I think that's true. Although I think there will always be a role for fusions, especially in the lumbar spine with patients that have spondylolisthesis. I don't know. It'd be hard to anticipate how. I mean, I guess it's possible that you could repair that. I mean, spondylolisthesis, obviously, it's where the bones slip significantly against each other, and there's an instability in the spine, and it is hard to envision a mechanical device being able to fix that. I don't know. Do you feel differently about that?
No, and when I say in 20 years we'll wonder why we ever did a fusion, I think I'm referring more to the cervical spine than the lumbar. And again,
Right.
that's a general statement. Of course, there's going to be a time or two where you have to do what you have to do. In the low back, it's still fusions, right?
Right.
And that's the change. You don't see people with hip fusions anymore. You don't see people
No.
with knee fusions anymore. They're all able to manage with a mobile joint. And you've got to believe that seeing as how the technology with disc replacements in the spine is only 20 years instead of 60 years like the hip and the knee, that those advances will take place someday.
Right. I do think, like, just thinking about my practice, I love doing cervical surgery, and as you know, the outcomes are almost uniformly positive and good. And cervical surgery, neck surgery, has a much better reputation among the patient population. They don't tend to be, scared to because they all know people that have had neck surgery and done well. I think lumbar surgery sometimes is a bigger challenge when patients need it to reassure them and help them decide to go ahead and have surgery. And sometimes I think as surgeons we're not 100% sure, if somebody's going to do really well from surgery. There are cases where they've tried everything else, and we put them through all the conservative treatment that we have to offer, and really their quality of life is so bad that we make a decision to do surgery, and maybe have a little bit of doubt that they're going to get a great benefit. But there are situations where, and when you see these patients come in with a slip spine, and they give you this common story, which is, I can only stand up for 10 or 15 minutes, and I try to cook dinner, or I try to stand and talk to people, and the pain just becomes excruciating, and I have to go lay down. And you see those patients, and you hear that same story, and you look at their X-rays, and they've got this slip in their spine, and I never want to have patients come in and be happy that they're suffering, but I'm almost happy when I see that situation, because that operation, the lumbar fusion for that scenario, is just absolutely a game changer, and it just changes people's lives. I mean, you've seen it thousands of times with patients coming in and telling you, the results and how happy they are with that. So, and I think there's a general kind of a fear of a lumbar fusion surgery in the general population, and it in the right situation, it's just a game changer for people.
Right. It is almost a strange feeling when you're operating on somebody and you see just the very worst kind of nerve compression. It almost gives you a positive feeling that
Right.
that person is going to have a good result, right?
Yeah.
And so, in a weird way, when it looks
Terrible.
you're like, well, this is good. This is a positive sign.
Well, there's good terrible, and then
Right.
there's
Right.
bad terrible.
I do.
We hope you enjoyed this edition of Back Talk. and learn something new. Look for other podcasts from Southeastern Studios as we explore the latest in medical procedures that are helping more and more people living in pain get back to their active lives.